Now I request Dr. Jaya Prakash to deliver the lecture about inherited retinal disorders prognostication.
Good afternoon, everyone. I'll be talking on predicting long-term prognosis in hereditary retinal disorders at presentation. So inherited retinal disorders are a large group of diverse disorders. There are more than 300 genetic mutations identified so far, and it leads to retinal degeneration, leading to severe visual impairment and blindness. And it's quite common, 1 in 3,000. It's very heterogeneous, and there is a genotype-phenotype mismatch. So when you encounter a patient, the patient has a lot of questions. Is it a hereditary disorder? Is it treatable? Will it progress? What are the chances of further visual loss? Can we halt the progression? What will be the final outcome? Do I need aids, and what aids do I need? How to plan my education, career? Can I drive? And will it affect my offspring or sibling? So these questions have to be answered, and that's why we are looking at this. So the first and foremost is to diagnose the inherited retinal disorder. So early and accurate diagnosis is very important. So we do it by a detailed ocular, medical, and family history, clinical examination, multimodal ocular imaging, systemic investigations, and molecular testing. Once the diagnosis is made, then we need an interdisciplinary approach, not only by the ophthalmologist, but by other specialists to cater to the biological, psychological, and sociological needs of the patient. So let's look at the crystal ball, see what are the prognostic factors. The age of onset, if it's a younger age of onset, then the prognosis is poor. Poorer vision at presentation leads to poorer long-term prognosis. Among the inheritance pattern, X-linked RP has got a poorer prognosis, whereas autosomal dominant has got a slightly better prognosis. Syndromic inherited disorders have poor prognosis, not only for vision, but for the life also, because they have a lot of systemic associations. One important thing is to differentiate between a progressive or a stationary inherited retinal disorder, because progressive, as you all know, has got a very good prognosis, whereas stationary have relative good prognosis. So you differentiate based on the history. The patient can tell that the condition is staying the same or it's worsening. Clinical examination, yes, and investigations, I'll cover that subsequently. The fundus findings also give us a clue. We have advanced findings and macular involvement. The long-term prognosis is poorer. Visual fields are also very important, and those with advanced field loss and macular involvement at presentation have very poor prognosis. ERG is very important. For example, this patient had 6/9 and 6 vision with the retinitis pigmentosa. You want to know how advanced, you do an ERG and is showing total loss of responses. But still, the patient does have visual potential. There's a small central peak on the multifocal ERG. In another patient in whom the central peak is also lost. So ERG can help in prognosticate. It can help in differentiating stationary or progressive. For example, there's an 18-year-old girl who came with nyctalopia with multiple flecks over the fundus. And the dark adapted full field ERG showed reduced scotopic responses. But on prolonged dark adaptation after 4 hours, it shows normalization of the ERG. So it's a stationary disease, fundus albipunctatus. Whereas in another patient with a similar finding, the ERG did not improve even after dark adaptation, and the patient had retinitis punctata albicans, so it is a progressive disease. Clinically also there are some findings that you have disc pallor, arterial attenuation, which can give a clue about whether it is stationary or progressive. ERG tells whether it is rod related or cone which is predominant. In this patient, it was the cones which are more affected. So in cone rod dystrophy, the poor central vision, so the visual outcome in the long term will be affected much earlier. Again, this patient who came with bullseye maculopathy, whether it's cone dystrophy or Stargardt's without flex, ERG can help us to diagnose, because at least in the early stages, Stargardt's without flex will have a normal ERG, whereas cone dystrophy will have a reduced response in the photopic. The other clues like loss of color vision and photophobia in a cone dystrophy. So to sum up, ERG abnormalities occur in the early stages before the symptoms and fundus abnormalities happen. It differentiates the different types of the disorders. It can diagnose atypical forms and is also quantitative. So if you're following up, you can tell the patient how the progression is going to be. In patients who have poor fixation, you can do a full field stimulus threshold, which is again coming up now because of gene therapy coming up to tell when to give the treatment. Multifocal ERG can be done in patients in which ERG is not recordable or in whom the retina appears clinically normal. So ERG is both prognostic in both the early and advanced stages. Coming to OCT, in the inherited retinal disorders, the interdigitation zone is the first which is affected, followed by the ellipsoid zone, the external limiting membrane, and finally the outer nuclear layer. So basically the photoreceptors are affected. So this is a patient who had retinitis pigmentosa with macular sparing. So you can see that the eyes interdigitation zone is spared in the central area, and the ellipsoid zone little larger area, and the external limiting membrane to a much wider area. So there are a lot of studies which looked at this. Both ellipsoid zone integrity and length, both are very important in prognosticating. And those with EZ loss at presentations have a poorer long-term prognosis. So there is a grading in achromatopsia based on the OCT. So you can see progressively how the ellipsoid zone and the other outer retinal layers are lost on the OCT. Hyperreflective foci in the outer retina, if present at presentation, again has a poorer prognosis. There are some choroidal parameters like thin choroid and reduced choroidal vascular index, which indicate poorer prognosis. Even the pattern of the choroidal vessels, like a normal appearing choroidal vessels has a good prognosis, whereas when the hallus atlas layers are reduced, the prognosis is poorer. And those who have choroidal caverns, there is even further worse prognosis. There are other concurrent problems in inherited disorders like ERM, macular hole, cystoid macular edema. And when these are present, again the prognosis is poorer. OCTA also has been used to look at capillary rarefaction and FAZ enlargement, and if it is present, indicates a poorer prognosis. Coming to autofluorescence, in about 50% of RP patients, we have hyperautofluorescent ring, which is known as Robson's ring. And the size of the ring is important. If it's a smaller ring, then the prognosis is again poor. So the different patterns described. If there is no ring, then there is usually no progression. If there is a ring, it indicates that there is a progression going on. Whereas in the advanced stage, there is either increased or abnormal fundus autofluorescence. Quantitative autofluorescence also coming up in a big way, and it is actually a surrogative marker for predictive genetic testing. And in this patient of Stargardt's disease, there has been an increase in the quantitative autofluorescence, which then reduces with the onset of the RP atrophy. Wide field autofluorescence is now available, and it corresponds very well to the visual fields. And if there is macular involvement, then again the prognosis is poorer. Wide field autofluorescence, the area of the hypoautofluorescence increases with age and disease duration, and more hypo areas means the prognosis is poorer. There are some biochemical tests, like in gyrate atrophy, we can do the plasma ornithine levels, and in beta lipoproteinemia, lipid profile can be done. And in these conditions, early detection, diet restriction, and supplementation, we can actually change the prognosis of the patient. Genetic testing, yes, we have now gone on to whole genome sequencing. I'll take about a minute more. And there are a lot of clinical trials, and we know that Luxturna is now available for therapy. Last, artificial intelligence is now being used to predict prognosis. It is based on fundus images, fundus autofluorescence, OCT, adaptive optics, pupillometer, and different combinations of these. So various algorithms and models have been described. And the machine, once it learns, it kind of gives the genetic diagnosis and also the prognosis for the patient. There are some limitations. To summarize, timely, accurate diagnosis is very important. Appropriate interdisciplinary management and the correct prognostication is important for the overall development, lifelong visual function, quality of life of patients with the inherited disorders. And artificial intelligence is going to be the future in prediction. Thank you. I would like to take this opportunity to invite you all to our 6th Retina Summit and 8th IROP annual meeting in July.
Thank you, Dr. Jaya Prakash.
Thank you, sir.
Sir, your words.
Well, I usually hate to see these patients. I usually send them off to another one, and Dr. Jaya Prakash did a great job of putting everything together. It was wonderfully placed. So if I was forced to counsel them, I would try to remain positive, though it may not look positive, the outlook, but then I don't tell them that, like, it's extremely difficult to say that, like, oh, you're going to lose vision in the next 3 years, 4 years. So I usually tell them, don't lie to them, but at the same time try to put a positive spin. So I may or may not be proven right, but I've been telling that like in the next 5 years you'll get a genetic gene therapy for the last 20 years. So it's not often that patient comes back and tells you like 5 years back you told me gene therapy will come. Where is it? So, but like you give them a like positive outlook, saying that like things are looking promising as compared to what was 15 years back. 15 years back there's no hope. Now there seems to be hope. Some forms of RP has a treatment, so I think that like probably in the next 5 years, 10 years, it can come. 5 years later, if they come, I'll tell them, yeah, it has come in USA, in India, probably another 5 years it will happen. But then like you give them the hope, so don't let them lose hope. Of course, like all the prognostic factors he has put across very, very beautifully. And other thing I look at is like look for treatable causes.
Yes.
So if there is a cystoid macular edema, if there's a schisis, or if there's an ERM, or there's a macular hole, then there is some treatment you can do to improve the vision. So you can use dorzolamide or systemic astazolamide, epiretinal membrane you can remove, macular hole you can close, and cataract. Cataract, once again, many of them have a posterior polar cataract, so you ask them if in case they have glare in the night, so cataract surgery can help. But of course, we need to be careful in telling them what it is. So the treatable causes I would look for and treat them. And if there's absolutely no possibility, still I tell them like, okay, let's see if there can be a cortical implant, there can be something. So you always give them a little hope, and check the offspring for genetic thing is a little doubtful. Nowadays I've been telling them to have a genetic testing for themselves, telling them that like let's have things in place. So subsequently later on, if gene therapy comes, maybe if you are eligible, then you can go ahead with the treatment. So I do have a gene therapy done, and that helps us to kind of precisely diagnose it. So even recently we had a patient where I was wondering if it was autoimmune retinopathy or hereditary degeneration. So we screened for autoimmune retinopathy, which is negative, and then hereditary degeneration. Genetic testing was done, and it did show something like that. Offspring, many times they ask, like, do we screen our children? I tell them best is to leave it alone, because like when you don't have a treatment, you screen and tell, yes, your son has got RP, adds another layer of additional stress to them. So best is to just, because when you have a treatment, it's fine. But when you don't have a treatment, then what is the problem? What is the thing? So I don't actively push them to have testing of their offspring, in contrast to what I do for retinoblastoma. So that's how I go about it. I don't think I can add anything more to what Dr. Jaya Prakash has covered.
Thank you, sir. Anyone has any question? Now, yeah.
It's to Dr. Jaya Prakash, I hope.
To you. Okay. Jaya Prakash, if a child comes, it's okay about the adult counseling. They have accepted the fact because they have accepted the fact for so many years now. But, sometimes in the OPD, the first case is a child, and they don't know the diagnosis. And it's, it's their first visit because the teacher has said that the pupil is not paying attention, and you discover head macular degeneration. And it's not very uncommon. So how do you counsel these parents? Because in India, we don't have a support program for these kids, not enough, quality blind school programs also. So what is your approach in these cases? Specifically a child who has been diagnosed for the first time and there is no acceptance when you tell them, because they are not ready to accept that something is wrong with their kid.
In our LVA clinic, we have they do the counseling part also, so that takes care of some of them. I counsel them in the clinic, tell them, but some of the part of the counseling happens in the LVA clinic. They have to accept, so.
Yeah.
But only thing is that we can tell them that it is not that end of life. They have support, even in India, though program is not there like for a particular diagnosis. We do have support clinics and supporting organizations. So we can always guide them for that. If it is very severe or if it is in the early stages, we can always tell them how to plan the life regarding the profession and other things.
The thing is to give them some time. Unless the child is absolutely blind, then give them time. We don't know how it will be. It may turn out to be, it may be slowly progressive. So give them some time, because like I come across this ROP stage 5s as well as retinoblastomas. Retinoblastoma, I tell them upfront, because like if they don't do the proper care in proper time, then it's going to be risky to the life. So, but otherwise I tell them, yeah, there is a possibility. Let's see, like it depends on how it goes, because we can never predict. Some children may still see. So I kind of beat around the bush the initial time.
That is not the end of the road, but at the same time we have to caution them about what not to do.
Correct. but subsequent visits, you tell them, okay, yeah, correct, maybe it's progressing slowly. Like bring out the news bit by bit, I think.
Because certain things like
Talking
driving
of
and all, I ask them to avoid.
So talking of ROP, sometimes you accidentally say ki this is the first time you are having a ROP screening. When you see a stage 5, so they directly blame the pediatrician, and then your colleagues are in a soup. After that, they go back and say
correct. That happens like not from the consultant point of view. It happens from the fellow's point of view, or when they are taking the history, it comes out inadvertently. That you would have to sensitize them probably.